if intimacy becomes painful, your brain will literally just shut off your desire.
Yeah, completely.
And it does this not because you're broken or, just aging or fundamentally deficient somehow. Your brain actually flips that switch to protect you.
It's a profound survival mechanism. I mean, it really completely reframes how we should look at intimacy later in life.
Right.
Because we tend to view lost libido as this mechanical failure, like a faulty part in a machine that just needs replacing.
Exactly. And that reductionist view is, well, it's exactly why treating menopausal sexual difficulties requires so much more than just slap it on a hormone patch.
Oh, absolutely.
So welcome to our deep dive today. We are taking a really close look at a very specific and I think often misunderstood tool curated for you from our sources, which is psychosexual therapy.
Right, and we've got a lot of ground to cover.
We do. We are looking at clinical guidelines from the European Menopause and Andropause Society. So EMES and the National Institute for Health and Care Excellence.
Which most people know as NICE.
Right. Plus, we have these really specialized training modules from the Institute of Psychosexual Medicine, the Contemporary Institute of Clinical Sexology, and articles from the Menopause Consortium.
And therapy directories, too, right? Like COSRT.
Yeah, the College of Sexual and Relationship Therapists. So it's a dense stack of material, but it really paints this unified picture.
It does.
And our mission for this deep dive is to uncover the exact role of psychosexual therapy in navigating all these profound physical and emotional shifts. But before we get into how therapy fixes the problem, we kind of have to redefine the problem itself.
We do, yeah, because menopausal intimacy issues are rarely just, broken biology.
Right. And there was this fantastic analogy in the Ability Radio source we reviewed. It referenced Dennis Daly's 6 circles model of human sexuality.
I love that model.
So good. Okay, let's unpack this for a second. Imagine sex not as like the physical bullseye in the center, but as the entire dartboard.
Which is such a vital distinction to make because the medical community frequently focuses solely on that bullseye,
Yeah.
Just the physical act, sensuality, and maybe reproduction.
But the whole dartboard includes intimacy, which is really how we connect and relate to others. It includes sexual identity, sexualization.
Right.
And those are all wrapped tightly inside this outer ring of, societal values and beliefs. So if you only look at the bullseye, you're just ignoring the vast majority of human experience.
You really are. And if we connect this to the bigger picture, this dartboard concept perfectly mirrors what EMES and other major medical bodies call the biopsychosocial model of menopause.
The biopsychosocial model.
Right.
Yeah, so to actually treat dysfunction, a practitioner has to look at all 3 of those interconnected layers at the exact same time.
Okay, let's pull those layers apart then, starting with the purely biological.
Sure.
The defining feature of menopause is a systemic drop in estrogen, which triggers this condition called genitourinary syndrome of menopause, or GSM.
And GSM is relentless because unlike vasomotor symptoms, the classic hot flash.
Eventually fade. Right, they might fade over the years. But GSM is progressive. Without estrogen, the cellular architecture of the vagina actually changes.
Oh, wow.
Yeah, you see the severe reduction in collagen. The epithelial tissues thin out drastically, elasticity just plummets, and natural lubrication practically stops.
And the sources describe the tissues becoming friable, which means they tear easily.
Exactly.
Which translates to this profound dryness and just intense tearing pain during penetrative sex, which is clinically known as dyspareunia.
That is the harsh biological reality. But then, we have to layer on the psychological and social realities.
The other parts of the dartboard.
Exactly. The menopausal transition frequently coincides with clinical depression, spikes in anxiety, massive shifts in body image.
Yeah.
And socially, a person might be navigating intense relationship conflicts or the compounding stress of caring for aging parents or even the sudden resurfacing of past sexual trauma.
Which brings us back to that fundamental biological rule we started with. When sex is intensely painful because of untreated GSM, losing your libido is actually a highly evolved response.
It's doing exactly what it's supposed to do.
Right. Your brain recognizes that this activity causes tissue damage. Therefore, the brain just shuts down the neurological pathways that generate desire.
It's classical conditioning. It's Pavlovian.
Yeah.
The nervous system links intimacy directly with the threat of physical harm. So the amygdala, the brain's fear center, It just takes over to make sure you avoid that harm.
Which makes perfect sense from an evolutionary standpoint.
Mm.
So once we understand this tangled web of biology and psychology and survival instincts, we begin to see why just handing someone a tube of estrogen cream might heal the tissue, but...
But it won't instantly restore a healthy sex life.
Right. And that brings us to the therapy itself.
Yep.
I do have to push back a little here, though, because I'm looking at these descriptions of severe dyspareunia and vaginismus, where the pelvic muscles involuntarily spasm. If the physical body is reacting that violently, how does sitting in a chair and just talking to a psychosexual therapist actually alter the pelvic floor?
Well, it highlights how dangerously disconnected we assume our minds and bodies are, you know?
How do you mean?
The Institute of Psychosexual Medicine, the IPM, they note that these sessions provide a highly confidential space to address what they call the unspoken word.
Okay.
They aren't just talking about feelings in a vacuum, they are directly addressing the reflexive muscle guarding that's happening in the body.
Reflexive guarding meaning the physical flinching.
Precisely. When the body learns to anticipate pain, the nervous system goes into this state of high alert before anything physical even happens.
Wow.
The pelvic floor muscles clench to protect the delicate tissues. Tragically, a hypertonic, clenched pelvic floor makes penetration significantly more painful.
Creating a vicious, self-fulfilling loop.
Exactly. So psychosexual therapy is not just conversational, it's an active rewiring of the nervous system's response to intimacy.
And the sources detail some highly structured techniques for this rewiring, the foundational one being sensate focus. From what I read, this is like a series of structured touch exercises you do at home with your partner.
Yes, and the crucial mechanism of sensate focus is that intercourse is explicitly forbidden.
Banned entirely.
And the EMAS guidelines specify that sexual activity does not need to be orgasm-focused or penetration-focused by entirely removing the pressure of hitting that bullseye we talked about earlier.
Sensate focus stops the sympathetic nervous system, the fight-or-flight response from firing.
Right.
It essentially tricks the brain into dropping its defenses. Couples learn to touch and be touched, purely to observe sensation, without the heavy expectation that it must escalate to sex.
And removing the threat of painful penetration allows the parasympathetic nervous system, the rest and digest, or in this case, arouse and connect system, to take over.
Wow.
The reflexive guarding in the pelvic floor slowly stops because the brain no longer perceives a threat.
The sources also point heavily to CBT, cognitive behavioral therapy, specifically to combat something called spectatoring.
Ah, yeah. Spectatoring is a fascinating psychological phenomenon. It occurs when a person is in the middle of an intimate moment, but their conscious attention just splits.
Like they step outside themselves.
Exactly. Instead of experiencing the physical sensations, their mind floats above them, observing and harshly judging their own performance.
Do I look attractive from this angle? Is this taking too long?
Am I taking too long to lubricate? All of that.
You are literally grading yourself in real time.
Yeah.
Here's where it gets really interesting for me, though. How does a therapist actually stop that internal monologue from happening in the moment?
Through highly specific CBT and mindfulness grounding techniques, when you are spectatoring, your brain's blood flow and electrical activity are concentrated in the prefrontal cortex.
Which handles all the complex analysis and judgment.
Right. So a therapist trains the patient to notice when that shift happens and uses sensory grounding, focusing intensely on the temperature of the sheets, the rhythm of a breath, a specific physical sensation.
To force the focus back to the body.
Exactly. To the sensory cortex. It quiets the internal critic by literally changing where the brain is allocating its energy.
And we also see a strong physical component integrated into this therapy. Pelvic floor muscle training, or PFMT, is frequently utilized alongside the psychological work.
Often in collaboration with a specialized physiotherapist, yeah.
But many people assume PFMT just means doing Kegels to tighten the muscles.
Right, which in the context of menopausal pain is often the exact opposite of what you need. It's really about learning to consciously relax hypertonic, chronically tense muscles.
Dropping the pelvic floor.
Yes. Consciously relaxing those muscles induces vasodilation, the widening of blood vessels.
Which brings the oxygen-rich blood back to the atrophied tissues.
Which is completely necessary for healing those microtears and restoring elasticity.
This true partnership between the mental and physical interventions naturally brings us to a massive societal debate. Society loves a magic pill.
Oh, we really do. We want a quick fix for everything.
Right. And recently, the narrative around testosterone as a kind of female Viagra for menopausal women has completely exploded.
It's everywhere.
What do the British Menopause Society and the Menopause Consortium actually say about the clinical data here?
Well, the clinical data is incredibly specific, whereas the public narrative is very broad. Testosterone is clinically indicated for hypoactive sexual desire disorder, or HSDD.
Okay.
It can be highly effective for a specific subset of individuals. However, the British Menopause Society stresses an absolute prerequisite. A patient must optimize their systemic and vaginal estrogen before testosterone is even considered.
The estrogen has to be addressed first. Why is that sequence so rigid?
The Menopause Consortium provides a brilliant clinical contrast to illustrate this. They talk about woman A versus woman B.
Okay, let's hear it.
So, woman A is on optimized hormone replacement therapy. She has effectively treated her genitourinary syndrome of menopause. There is absolutely no physical pain or tissue friability during intimacy.
Okay.
She has a loving relationship and stable mental health. Yet, despite all systems being seemingly functional, she suffers from a persistent, distressing lack of desire.
Her dartboard is completely intact, the tissue is healthy, but the biological drive is just absent.
Yes. Woman A is an ideal candidate for a clinical trial of testosterone. It may provide exactly the neurochemical boost she needs.
Got it. And woman B.
Now look at woman B. She has untreated GSM, making sex excruciatingly painful. The distress from this pain, and perhaps other menopausal symptoms, has led to a prescription for SSRI antidepressants.
Okay.
She's also exhausted from caregiving and has unresolved conflict with her partner.
I want to pause on the SSRIs for a second because the sources note they notoriously kill libido.
They do, and the mechanism is really important here. Selective serotonin reuptake inhibitors flood the synaptic clefts in the brain with serotonin to stabilize mood. But serotonin and dopamine operate on a kind of neurological seesaw. When serotonin is artificially kept high, it can suppress dopamine.
Which is the primary neurotransmitter responsible for sexual craving, seeking behavior, and the physical ability to achieve orgasm.
Exactly. So woman B's dopamine is suppressed by the medication, her tissue is tearing due to estrogen loss, and she has relationship stress.
Wow.
Trying to fix her libido by simply handing her a testosterone gel is like trying to force a car to accelerate while the emergency brake. Her brain's fear response is permanently welded shut.
It will only lead to profound frustration.
It will. Testosterone cannot outcompete severe physical pain, neurochemical suppression from SSRIs, and deep interpersonal conflict.
So what does she actually need?
She needs local vaginal estrogen to shield the epithelial tissue, a medication review with her doctor regarding the antidepressants, and psychosexual therapy to dismantle the fear of pain and address the relationship dynamics.
This clinical scenario perfectly illustrates the gap in the healing process that only therapy can bridge, because the timelines for medical healing versus psychological healing are vastly different.
Yeah, the physiological healing is relatively quick. If a patient begins localized vaginal estrogen therapy, the tissues will typically plump up, regain elasticity, and heal within 4 to 12 weeks.
So the biological hardware is repaired in a couple of months.
But the desire could take 6 months or a year to return.
Wow.
Because the brain's fear response, that deeply ingrained anticipation of pain, takes significantly longer to unlearn than it takes for tissue to regenerate.
That makes total sense.
The medication heals the physical tissue, but the psychosexual therapist helps the brain unlearn the trauma so the patient can actually tolerate using that healed tissue without reflexive guarding.
So what does this all mean when we expand our view to the wider context of a patient's life? This deeply nuanced partnership between medicine and therapy proves that care has to be highly individualized.
Absolutely. Menopausal individuals are not a monolith.
No, they aren't. Which brings us to the therapy directories we reviewed.
Right, which raises an important question about how therapy adapts. The directories from the Contemporary Institute of Clinical Sexology, or CICS and COSRT, they place a massive emphasis on practitioners trained in GSRD.
GSRD standing for Gender, Sexual, and Relationship Diversity. And they also highlight specialized training for neurodivergence and chronic illness. Because menopause doesn't happen in a sterile laboratory, It crashes into a person's existing reality.
We see this acutely in the LGBTQ plus gaps highlighted in the sources. Consider a transmasculine person or a trans man who has retained their ovaries and is experiencing menopause, whether surgically induced or age-related.
Okay.
They can experience severe genitourinary syndrome of menopause.
But the standard reflexive medical advice of just apply this vaginal estrogen cream every night is highly problematic in this context.
It can be deeply traumatic. The physical application of a hormone-based treatment to that specific area can trigger intense, debilitating genital dysphoria.
That sounds incredibly difficult to navigate.
It is. Navigating this requires a psychosexual therapist who is deeply knowledgeable and affirming. They must help the patient manage the physiological need for tissue health while finding workarounds that respect, protect, and validate their gender identity.
It creates a safe container to re-engage with a changing body. And we see a similar need for highly specialized care in the sources covering chronic illness, particularly the data on Parkinson's disease.
Yeah, Parkinson's presents a remarkably complex intersection. The rates of sexual dysfunction are incredibly high, almost double that of the general aging population.
But the challenges are multifaceted, right? The disease itself causes rigidity, tremors, and a loss of autonomic functions.
It does, but the medications used to treat Parkinson's add another layer entirely.
Because the medications are often dopamine agonists.
Yes, they artificially flood the brain with dopamine to improve motor function. But as we discussed earlier, dopamine drives sexual-seeking behavior.
Right.
This can lead to hypersexuality or new compulsive sexual interests happening in a body that physically struggles to execute those desires.
The amount of shame surrounding that mismatch between mind and body must just be immense.
The shame is often paralyzing. A skilled psychosexual therapist helps individuals with chronic illnesses grieve the physical functions they have lost.
Yeah.
They help untangle the shame of medication-induced hypersexuality and guide the patient in discovering alternative pathways to arousal and intimacy when their body is moving involuntarily or experiencing chronic pain.
It is about redefining pleasure on entirely new terms. Which brings us to perhaps the most pervasive environmental intersection mentioned in the EMAS guidelines, ageism. The sources use a highly specific, striking term, ageist erotophobia.
Erotophobia is the societal disgust or deeper version to the very concept that aging bodies are or should be sexual.
Society is deeply comfortable desexualizing older women. The prevailing cultural narrative basically insists that once the reproductive utility is over, a person should essentially fade into the background, put on a cardigan, and abandon their sexual identity.
And that pernicious narrative infiltrates our healthcare systems, our clinical trials, and our care homes. Older adults internalize this disgust and stop advocating for their own sexual health.
It's tragic.
It is. Psychosexual therapy actively wages war against ageist erotophobia. It boldly affirms that sexual rights, the desire for touch, and the need for intimacy do not suddenly expire at age 65 or 85.
The sources even discuss how therapy supports individuals transitioning into assisted living or nursing homes, actively advocating for their fundamental human right to privacy and physical connection, rather than treating them like children.
Because dignity does not have an age limit.
Absolutely. As we synthesize everything we've pulled from these guidelines, directories, and clinical modules, a few core truths really emerge from this deep dive. First, the menopausal transition is absolutely not the end of a person's sexuality. It's a profound, albeit challenging, transition.
It requires a significant adjustment of expectations and mechanics. But it is a new chapter, not the conclusion of the book.
And psychosexual therapy serves as the vital translation tool. It helps you unlearn the brain's deeply ingrained fear of pain, provides a framework to communicate rapidly changing needs to a partner, and fundamentally redefines intimacy far beyond just the mechanics of intercourse.
It takes the pressure off hitting the physical bullseye and illuminates the entire dartboard of human connection.
For you listening, the ultimate takeaway from these sources is that your sexual health is a legitimate, critical pillar of your overall well-being. It is completely valid to ask your doctor for this specific help.
Definitely.
The NICIC guidelines do acknowledge that waitlists for specialized CBT and psychosexual therapy within public health systems can be frustratingly long. But the journey to reclaiming your body and your pleasure is worth undertaking.
You do not have to quietly accept pain or dysfunction as an inevitable consequence of aging. There are evidence-based pathways to heal both the tissue and the trauma.
I want to leave you with a final provocative thought to mull over, building on a quiet detail buried in the Menopause Consortium sources.
Oh, the mental load.
Yes. When listing the compounding psychological factors of low desire, they mention the mental load, the sheer exhaustion of caregiving for children and aging parents, financial strain, managing a household, sustaining a career. These are identified as massive libido killers.
Because those factors lock the nervous system into a chronic, unyielding survival mode.
So consider this. How much of society's pervasive narrative around lost desire in aging women is actually just a perfectly natural, healthy biological response to chronic exhaustion and a wildly unequal mental load?
It's a huge question.
What if treating menopausal sexual difficulties isn't always about fixing a broken physical body, but about radically changing the exhausting environment that bodies forced to exist in?
That is a fundamental question about how we structure society, and it is absolutely worth exploring.
Something to think about. Until next time.